antibiotics. It is a very new topic. I think a lot of us might have confusions regarding this. There is no clear-cut guideline as of now, at least from any of the societies. There is no strong evidence to support it. But still, we think as pulmonologists, it will be worth it to have a detailed discussion to get clarity about where we stand in terms of this particular topic. And I have some very well-versed and esteemed panel with me today, which I would like to introduce to you all. So I am myself Dr. Shivani Swami. I am a consultant pulmonologist at Narayana Multispeciality Hospital, Jaipur. And we have three very well-known doctors with us. So first is Dr. Rubeena Rathi. Dr. Rathi is actually MD Pulmonary Medicine, and she has also done a fellowship in interventional pulmonology. She is currently a consultant pulmonologist and critical care at the Rathi Hospital in Aligarh. So welcome, Dr. Rubeena, and thank you for being with us. Our second panelist is Dr. Richa Mithal. Dr. Richa Mithal herself is a DM Pulmonary and Sleep Medicine. She has also done her MD, DNB, and European Diploma in Respiratory Medicine. She is currently a consultant pulmonary and sleep medicine at the Sir H.N. Reliance Foundation Hospital in Mumbai. Our third and very esteemed panelist again is Dr. Joydeep Ganguly. Dr. Ganguly is MD Pulmonary Medicine. He is MRCP from the UK. He is also European Diploma in Respiratory Medicine holder from Europe. He is currently a consultant pulmonologist at the Leela Hospital at Murshidabad in West Bengal. So welcome to all of you and thank you for joining us. So for people who are still joining in, I would just like to tell you that the flow of the program actually goes like we do a brief presentation on the topic, after which we will go on to panel discussion with the esteemed panelists. And from there, we will move on to taking questions from the audience. So if any of you have any questions, you can type those in your chat box. So that's how we proceed with the program. And without wasting any further time, I think we will move on to the presentation. Good evening, everybody. I'm Dr. Shivani Swami, a consultant pulmonologist from Jaipur. We are here today to talk about the role of nebulized antibiotics. I'm sure all of us have forever been using nebulizations in various forms for various drugs. But how many of us are actually using nebulized antibiotics? So we are here today to discuss about this extremely scientifically about the use, the pros and the cons of the various nebulized antibiotics, so that we can practically put this into our use in our clinical practice. So in the flow of the talk, I will actually be talking about the mechanism, the types of nebulizers that are available, the various ventilator parameters that actually affect the aerosol deposition, and the various drugs that are basically available for aerosol therapy. So beginning with the aerosols, basically what is an aerosol? It is defined as a suspension of liquid or solid in a gaseous medium, the aim of which is to deliver a therapeutic dose of the drug to the desired site of action. In our case, mostly it will be the lungs. The advantages of nebulization per se are various. It, of course, delivers high drug concentrations directly to the disease site, minimizes risk of systemic side effects, has rapid clinical response, bypasses barriers to the therapeutic efficacy, all these such as the poor GI absorption, the first pass metabolism in the liver, and also it achieves a similar or superior therapeutic effect at a fraction of the systemic dose with minimal side effects. So what basically the aerosol system includes? It of course includes the drug, the aerosol device, the patient's respiratory system, and of course in many of our cases also the ventilator system. So what basically is the efficiency of the aerosol system? The aim of this system is basically to produce aerosols, like we've discussed, with characteristics suitable for drug delivery to the lungs. The basic performance of the system basically depends on two things, that is the emitted dose and the fine particle fraction. So the overall efficacy of the aerosol system is actually a composite of these two factors, which actually determines the dose delivered to the lungs and the lung bioavailability. The characteristics of these aerosols basically in the therapeutic dose basically are the aerosol output, the particle size, the lung deposition, and changes in the aerosol over time, as in from 1 hour to the other, in a few days, in a few weeks, as it ages, how the characteristics of the aerosol changes. The mechanism basically is very simple and is affected majorly by three things, which are impaction, sedimentation, and diffusion. So impaction is basically turbulence and high air velocity, which is associated with aerosolization and is prominent in the first 10 branches of the respiratory system, which we are all aware of. When it comes to sedimentation, that basically acts in the distal 5 to 6 airways and predominates due to the lower air velocity. However, if we look at this diagram, we understand that diffusion is something that basically defines the drug delivery, and it is best when the particle size is around 2 to 5 micrometers. So that is the ideal size of the aerosol for maximum deposition into the lungs. This is a very simple diagram which basically, which basically is talking about a lot of the other factors that we'll be discussing later, which includes the ventilator related, the circuit related, the device related, the device as per nebulization related, the patient related, and of course the device related. So these are the things that we'll be discussing in detail in the subsequent slides. So what are the basic general factors which affect drug delivery? The most important and the first that come to our mind are basically airway anatomy and physiology, that is abnormal airways and impact mucociliary clearance, which serves as a barrier to effective aerosolized drug therapy. So in our patients who will be pretty sick, these are things that we need to be really keeping in mind. Also, we need to be sure about the regional lung aeration. So when people have come to us, they practically have diseased lungs. So we need to keep in mind that what is basically the regional lung aeration, because in cases of pneumonias, that is certainly going to be affected. So airflow is not homogeneous throughout the lungs, especially not in diseased lungs. And lung diseases which are regional add to the heterogeneity of this regional airflow. So this is a very simple diagram which basically shows the difference in the effect of regional lung aeration in pneumonia on drug concentration in lungs. If we see these two graphs, one at a time, so we are actually talking about giving amikacin in a parenteral form, that is injectable, intravenous, as well as the nebulized form. And we do see here that the percentage of lung aeration is actually, when given in a nebulized form, the concentrations are actually much higher, even though the percentage of lung aeration is compromised. And similarly, when we look at people who have a focal pneumonia versus severe pneumonia, there also we see that actually the dose of nebulization is the concentration is much better when we compare it with just intravenous use of antibiotics. So basically what I'm trying to say here is that even when there is focal aeration happening, even there the reach of nebulized antibiotics is much better. The various aerosol devices that we actually have and we know is nebulizers. But then, of course, do we know that there are many types of nebulizers out there in the market? There is the jet nebulizer, the ultrasonic, and the mesh nebulizers. But other than that, when even in a ventilator where we can actually give antibiotics, that is the pressurized meter dose inhaler, that is the PMDF, which all of us are very well aware of. I'm going to take you through the various types and various advantages of the nebulizers that we have in the market. So what basically are jet nebulizers? They generate pressurized gas at a high velocity through a small jet orifice. The pressurized gas shear liquids into droplets due to the surface tension. So basically, this is the most common nebulizer which we see locally available even at the chemist shop, that people usually buy, have at homes, and even a lot of small hospitals, clinics, everybody has these jet nebulizers. So most easily available are actually and commonly used even in the rural areas is jet nebulizers. They were basically designed for delivery of various bronchodilators, and only about 5% of the aerosol which is delivered through this is respirable, the remainder of which is removed by impaction and then returned to the reservoir. And then it basically actually again gets into the system and is again generated into aerosols. So, of course, the time that the patient ends up taking this kind of nebulizer is for a longer time. We basically know that cleaning is to rinse after each use and boil wash weekly, especially the mask that is being used is also sometimes to be replaced at regular intervals. We cannot just go on using it endlessly. But it has a very, very short lifespan. So you typically ask the patient to replace it after 30 days or 6 months. So, but that is something which is not really very commonly practiced in India until it actually breaks down. I don't think anybody replaces it. Then coming to the more advanced nebulizers, which is the ultrasonic nebulizer. It basically uses a piezoelectric transducer, which in turn produces ultrasonic waves. The frequency of these waves is actually inversely related to the particle size of the aerosol, whereas the amplitude of this crystal vibration is directly related, it's directly proportional to the drug output, which is finally delivered by the nebulizer. So these are the two factors, that is the frequency of the ultrasonic waves and the amplitude of the crystal vibration. So these are the two factors that basically decide the drug delivery in terms of the aerosol size and the drug output. So the factors that basically affect the ultrasonic nebulizers are characteristics of the liquid solution, that is the viscosity, density, and the surface tension, the piezoelectric transducer in terms of vibration frequency and the vibration amplitude, like we've discussed, and of course, the size of the medication chamber. The various problems that we actually see when we are using an ultrasonic nebulizer. So the drug over time actually becomes more concentrated when we are using this kind of nebulizer, and the solution temperature also increases, sometimes by up to 10 degrees Celsius to 15 degrees Celsius, only after initiating, immediately in a few minutes after initiating the nebulization process. So this increase in temperature basically very commonly will denature most of the antibiotics, because 10 to 15 degree Celsius rising temperature is quite a high rising temperature. So we will not be sure about how effective the delivered drug is going to be actually. Then coming to the most advanced, the most recent vibrating mesh nebulizer, I'm sure a lot of hospitals are using it, especially the super specialty ones. So this basically has a piezo element which vibrates this mesh, and the vibration pumps liquid through the mesh. The liquid is emitted from the mesh in droplets, generating the aerosol. 100% of this aerosol produced by the mesh is respirable. So the one challenge that most of us would actually face with the vibrating mesh nebulizer is that a lot of these equipment are actually not manufactured in India. So when we look actually at these drugs which are available for nebulizations overseas, are not in a liquid form. So the mesh that they use and the mesh that should actually be used in India is going to be totally different, because if we use our nebulizer solutions with the ones that are available overseas, they basically sediment onto the mesh and the drug delivery is compromised. So those are things that we have to be really cautious about, and we should know about before we initiate somebody on a vibrating mesh nebulizer. Of course, cleaning is required, rinse after every use, wash daily and boil weekly, often using distilled water. And the mesh replacement typically is required after 6 or 12 months, so which is actually a pretty long time. And coming to the age-old gold standard method of aerosolized drug delivery, which we have all been using, is the pressurized MDIs. They are small, portable, convenient. Multiple doses are available in a single chamber and an excellent way of delivering drug. The only thing is that I do not think that very many antibiotic PMDIs are actually available in India currently. Of course, there is a delay between MDI actuation and inspiration. If there is a delay, it reduces the aerosol deposition, and of course, basically because of the sedimentation and electrostatic charge, and we are all aware of that. Also, it is extremely important the patient is able to synchronize the pressing of the PMDI with the patient's inspiration. Otherwise, the drug delivery is further compromised, sometimes by up to almost 35%, which is pretty high. But we can also use this PMDI, not to, of course, because the antibiotic variations are not available yet in India. But even when we are delivering bronchodilators, we can actually use it even in ventilated patients. And we are going to discuss the various ways where we can use nebulizers or PMDIs in a ventilated patient very shortly. So this is basically, this is a figure which is actually showing the aero chamber HC, which can be actually connected to a mechanical ventilator, and it's designed for use during mechanical ventilation. So that's where you can actually attach the aero chamber MDI actuator, with which you can use the MDI when you're giving it to a ventilated patient. So this is a beautiful slide which actually talks about all the brief points comparing all the inhalational methods that are available. And I would only like to highlight these few points that we need to be sure that, see, the residual volume is actually lowest in mesh nebulizers. Of course, it's not applicable when it comes to MDIs, but it is lowest in mesh nebulizers, and also the treatment time, the time that it takes for the drug to be delivered, is shortest when we're using mesh nebulizers. So these are certainly some advantages of the mesh nebulizer. Also, the noise level is pretty low, and you can, mix drugs if you want to. So all these advantages are certainly there, which are not available with, at least you cannot mix drugs when you're using the MDIs. So this is basically a figure which shows that when a patient is ventilated, what are the positions that we can actually use the nebulizer chamber, where all can we connect the nebulizer chamber to effectively ventilate the patient and also ensure the drug delivery. So there are basically these three positions. So looking at position 1, which is basically in between the endotracheal tube or the tracheostomy tube and the connecting tube of the ventilator. So that's basically the position 1. Position 2 is again at the inspiratory limb of the ventilator. Even after the ET tube, after the connector, when at the end of the inspiratory tube. So one end is connected to the ventilator, the other end, which is connected to the ET tube and the ventilator tubing connector. Just before that, we can put, this is the position 2. And the third position is putting right at the beginning of the inspiratory tube at the end of the mechanical ventilator. So these are the three positions wherein we can put these nebulizer chambers when we want to effectively deliver nebulized drugs to a patient. So again, this is a small figure which basically shows the difference between the inhaled drug mass between the various positions that we have discussed. And like we see, whether it is heated or humidified or non-humidified, with the various, nebulizer, the ultrasonic nebulizer, it is basically best in position 2. So that's about. And so just summarizing this entire figure, the jet nebulizer delivers maximum aerosol at position 3, that is towards the inspiratory limb of the mechanical ventilator. It has been hypothesized that the continuous airflow driving the jet nebulizer allows aerosols to charge the inspiratory limb of the ventilator circuit, and which practically functions as a reservoir and hence improves the aerosol delivery. In very stark contrast to this, aerosol from the ultrasonic and the vibratic mesh nebulizers at position 3 tend to collect at the aerosol generator and are not to be transported to the patient until gas from the ventilator flows from the ventilator. Then, of course, there are a lot of nebulizer-related factors also which have a role to play. So we all know that intermittent nebulization is better than continuous nebulization, and actually affects, especially during mechanical ventilation, has as much as a fold for greater inhaled dose compared to continuous nebulization. So certainly the benefit of intermittent nebulizations are much more. Then there are the circuit-related factors like the gas density. So the delivery efficiency of aerosol devices during mechanical ventilation and the gas density are actually inversely related. Then there is the heliox, which basically has a lower density, is not effective in generating aerosols, especially with jet nebulizers, and therefore it should not be used with jet nebulizers at all. The size of the endotracheal tube. So aerosol deposition was actually found to be significantly lower with smaller ET tubes. And but when we were using a jet nebulizer, the delivery efficiency when compared between a 7 millimeter tube with a 9 millimeter tube was actually much better. So it's almost actually comparable. Coming to patients who are basically tracheostomized, there will be a lot of these patients in your ICUs who will be tracheostomized. They may or may not be on a mechanical ventilator. Sometimes they are just on a TPs or they're just on oxygen, not on oxygen. So in these patients, the TPs interface between the tracheostomy tube and the nebulizer has demonstrated very good results, is very effective, and is actually more effective than a tracheostomy mask. Tracheostomy tube basically was not a barrier to lung deposition because 3% of aerosols deposited on the tracheostomy tube, because of course the dead space is much less when we compare it with the endotracheal tube. The modes of ventilation. So a lot of studies have been done on this. There is a lot of work which shows that aerosol deposition within the lower respiratory tract is actually more with CPAP or pressure supported ventilation rather than controlled mechanical ventilation. The use of PEEP also, especially during aerosol therapy, was found to improve lung function in spontaneously breathing patients, especially adults, which was more useful in delivering therapy than when it was done without giving PEEP. So PEEP was also always helpful in delivering, improving the drug delivery to the lungs. The other parameters is, of course, tidal volume, not directly proportional at all to the drug delivery, and as long as it is a decent tidal volume. However, a tidal volume of greater than 8 to 10 ml per kg can result in volutrauma and should not be used. So the average, if you're using somewhere between 4 to 6 ml per kg, it's a good enough tidal volume to deliver the drug to the desired area. Then the inspiratory time, directly related again to the aerosol deposition. So the cycle obviously has to be complete. If the inspiratory time is too short, then the drug delivery is not going to be effective. But at the same time, we have to be very cautious about using the, also measuring the degree of intrinsic PEEP that it is generating, because it may worsen dynamic hyperinflation in these patients, and then, especially in patients who have airflow limitations, and then actually that becomes a vicious cycle that we want to not start. Coming to the inspiratory flow, lower inspiratory flows actually increase aerosol delivery to the ventilator-dependent patients. Peak inspiratory flow should be decreased as much as possible if this is tolerated by the patient, and decreasing inspiratory flow from 80 to 40 liters per minute actually was found to improve aerosol deposition by almost 2 times in these patients who are on ventilators. The very important point, heat and humidity, which I think all intensivists and all pulmonologists love to talk about. So heated and humidified ventilator circuits actually led to decrease in aerosol deposition by changing the size of the aerosol particles. Humidity during aerosol therapy in ventilator-dependent patients was actually found to increase particle size from 1.5 to 2.3, which is quite a significant increase. And 40% less aerosol was deposited in these patients who were basically on heated and humidified gas compared with non-heated or non-humidified ventilator circuits. So when we are talking about heat and humidity, we should actually always remember that when we are using, it'll be more cost effective to be using dry circuits, especially when we are using expensive drugs, because if we use heated or humidified circuits, there would be a lot of drug loss. So when we're using dry circuits for those 10 minutes, 15 minutes, we can, when we're nebulizing the patient, we can put on a dry circuit and then put the patient back on a heated and humidified circuit. So it basically is very cost effective. Also, heat and moisture exchangers, which are very commonly used, they basically act as a barrier to drug delivery when it comes to aerosolized drugs and should not be placed specially between the artificial airway, which is the endotracheal tube or the tracheostomy tube of the patient, and between the aerosol device. So if they are actually further away from the aerosol device and the patient, it's all right. But in between these two places, there should not be any heat and moisture exchangers placed. So why are we talking so much about the use of IV colistin or nebulized antibiotics? Because there are a lot of studies. I'm going to show you a little bit of data to basically just reiterate what we've been talking about, the use of inhaled antibiotics or aerosolized antibiotics, how useful it basically can be. So the efficacy of aerosolized colistin when it was used in the treatment of ventilatory associated pneumonia, as you see in the current chart, was no way inferior to the use of IV colistin, whether it was used in monotherapy or even in a combination therapy. Of course, the incidence of side effects, especially acute renal failure when it comes to colistin, was much, much less when we were using aerosolized colistin. And this was a good study which had basically come out. This is a meta-analysis done on the use of aerosolized colistin in the treatment of ventilator-associated pneumonia. It basically collected data from 16 studies with a total number of around 690 patients. And the primary outcome that was studied was that there was a significant improvement in clinical response when aerosolized colistin was used. The secondary outcomes which were actually concluded from this entire meta-analysis was that, of course, there was a very significant amount of microbiological eradication. The infection-related mortality was significantly lower, although the overall mortality was not affected, but the infection-related mortality due to VAP was much less when we were actually using aerosolized colistin. Of course, there are limitations of using aerosolized drugs. Bronchospasm, like we are all very much aware of, especially when we are using nebulized antibiotics. But once a patient gets bronchospasm with a specific class of antibiotic, it is not advisable to use the same class or the same antibiotic in the same patient. Also, the most dreadful complications, especially in the ICUs, that we have to be very, very careful about is obstruction of the expiratory filter by the aerosol particles, which can actually even lead to cardiac arrest and death. But it's a very, very rarely seen complication, especially if you're following all other ICU protocols. So that's all about aerosolized antibiotic. There is an exhaustive list of antibiotics which can actually be used in an aerosolized form, which we will actually discuss with our panelists further. So I think we will now move on to the panel discussion. We have a lot of questions, and firstly, we will be asking our own questions, and then, of course, the audience are welcome to type their questions in the chat box, and we will take them towards the end of the conversation. So coming back to our esteemed panelists here, so I would go back to questions, and I would like to start with you, Dr. Ganguly. So which are these antibiotics that we can actually use through the nebulized route?
Hi, Shivani. Good evening. So, the story of nebulized antibiotic actually started back approximately 72 years ago, when in 1950s, some doctors started to giving aerosolized penicillin G in purulent bronchitis and pneumonia. but it was a failure because that is have not got serious effects, but only some bronchospasm and tingling sensation and there. The first one that we got as a published literature is in about Pines et al. And he actually what they do, they put gentamicin and colistin in chronic pulmonary bronchitis. Then we have this Hudson et al., which published a study regarding aerosolized carbenicillin and gentamicin with treatment of Pseudomonas or aeruginosa infection in patient with cystic fibrosis. It's in 1981. Then we have some record-breaking studies and many good trials regarding cystic fibrosis, uses of Pseudomonas infection in 90s that got more interest in this nebulized antibiotic. Currently, we have 3 FDA-approved antibiotic for inhalation and 1 European medicine agency approved antibiotic for inhalation. So what are those? We have azithromycin for inhalation solution. This is approved by FDA. It is to improve respiratory symptoms in cystic fibrosis patient aged more than 7 years, especially with Pseudomonas aeruginosa. We have tobramycin inhalation solution or TSI. It is approved management of cystic fibrosis in patient aged more than 6 years with Pseudomonas aeruginosa. It is also approved by FDA. We have tobramycin inhalation powder of TIP, which is used actually in management of cystic fibrosis patient aged more than 6 years in Pseudomonas aeruginosa infected. It is also approved by FDA. Another thing is colistimate sodium or colistimate dry powder for inhalation that is actually used in management of chronic pulmonary infection due to Pseudomonas aeruginosa in patient with cystic fibrosis, also in aged more than 6 years. It is only approved in European Medicine Agency, but it is not approved in US because some event was there, some death of some patients. Actually, then FDA banned this colistimate sodium inhalation powder or inhalation solution. So ultimately, we have this tobramycin, azithromycin, and this colistimate sodium, and in some studies, we have also some levofloxacin and ciprofloxacin inhalation powder and solution for inhalation, but they are not commercially available. And now the study is also happening with the gentamicin and liposomal, especially the liposomal preparation of ciprofloxacin and amikacin as a got of reporting us there. So in the next, we may have this kind of more antibiotics. So no.
So Dr. Ganguly, this was about what is available internationally, but can you just, for our viewers, summarize which one of these are available in India?
Yes, in India, we actually has got in my state, West Bengal, I have inquired with all the ICCUs and all the hospitals, only 2 things. Tobramycin we are using for a long time for non-cystic fibrosis bronchiectasis. We have tobramycin solution for inhalation about 300 milligram twice a day. And another is we have colistimate sodium, and it is not as per se available as a inhalation solution, but we make it to give as an inhalation solution, especially in case of ventilators as pneumonia and such cases. So I think these 2 would be the most primary cases.
Correct. So Doctor, I would just like to summarize that Dr. Ganguly says that actually currently in India, only colistin and tobramycin are available. Tobramycin doses to 300 milligram twice a day. And colistin, what is the dose that you use, Dr. Ganguly?
Colistin, actually, it is in a million units. So biological units, it's having this 10 units and 10,000 to 25,000 million units, actually, not 1,000. So it is, but it is not at per se available as an inhalation solution. We actually make it up with reconstitutes to use it as a nebulization solution.
So I think one brand has actually come up with the solution, and they come in the strength of 1 million units. They come in the strength of 1 million unit, and at least what the dose that I use is 1 million units nebulized thrice a day, along with the systemic dose, which is, so I use it as adjunctive therapy. And although there are a lot of studies which have actually studied a higher dose up to even 9 million units or 10 million units of inhaled colistin. So anybody else wants to add anything? Dr. Richa, Dr. Rubeena?
I guess same dosing that we use in nosocomial pneumonia also, 1 million unit TDS, and maybe in the chronic infections of bronchiectasis cases, 1 million units BD dosing is also something that we use for a long time.
Same here. We do agree with what he said, but just to add on to it is when the colistin nebulization as an antibiotic is used, So at times it gets degenerated with higher temperatures, ultrasonic. So we need to use a higher dose. Sometimes 2 million international units of 4 is also being used internationally.
Right. I think that's a very valid and excellent point. So, Dr. Richa, I would like you to tell us that what basically are the indications where we used aerosolized antibiotics. I mean, we're talking about aerosolized antibiotics. Now we know that, tobramycin and colistin is what is available here in India. So, but which patients is that subset where we can actually use inhaled antibiotics as a standalone treatment or as adjunctive therapy?
So we basically look at two types of conditions. So acute infections or chronic infections, more of colonization. When we are looking at acute infections, we are talking about eradication of the organism. And in the chronic infections or maybe colonization of the airways, there we are looking at eradication if possible. Yes, that's good. And if not, then we are trying to decrease the burden of the bacteria, and so as to cause decrease in the inflammatory response that's happening. In the chronic conditions, cystic fibrosis has long been inhaled antibiotics has long been used in cystic fibrosis patient, whether it's tobramycin, astronam, or colistin. Then in non-CF bronchiectasis, also colistin is very well recommended and is usually given for 3 to 6 months. And even then, although not very commonly used in India, but inhaled gentamicin is also used, whether the patient is chronically colonized with Pseudomonas or any other pathogenic microorganism for that matter. Even nebulized gentamicin is an alternative agent that is available for aiming at eradication or at least decreasing the burden of the bacteria. There are studies wherein COPD also, when patient has chronic Pseudomonas colonization and patient is coming with frequent exacerbation, where you can target decreasing the bacterial load, because ultimately chronic colonization with Pseudomonas bacteria leads to high morbidity and mortality. So we are aiming for a better quality of life and decreasing these complications. And there are studies which shows that we can use in COPD patients also. Then again, a chronic infection is NTM, where nebulized amikacin is used, specifically in MAC and M Mycobacterium abscess infection, where in the continuation phase, nebulized amikacin is used for long, at least 3 to 6 months. Then there are acute infections like ventilator-associated pneumonia, hospital-acquired pneumonias, where we are targeting MDR pathogens, where it's more of an adjunctive therapy with IV antibiotics. Nebulized colistin has long been used, and it has proven a clinical, as you said, as you highlighted also, it has proven as a clinical cure, better rapid response, and also a trend towards improving the mortality. So inhaled colistin has long been used. And also, if the patient doesn't have an MDR, in VAP patients, in patients with ventilator-associated pneumonia, if the patient is not responding just to IV antibiotics, we can also use inhaled antibiotics in these patients, even though if the patient doesn't have MDR pathogen. There is another indication in post-lung transplant patients, the antifungals, the nebulized amphotericin Bs, then pentamidine as an alternative agent for PCP pneumonia. In immunocompromised patient, post-lung transplantation patient, these antibiotics, these inhaled antibiotics are used not just for the treatment, but also as a preventive or a prophylaxis regimens. So there are a wide spectrum of diseases where we can use, and it's basically classified into a chronic infections and acute infections.
Right. So Dr. Richa actually told us that what are the various conditions, including chronic and acute, and also prophylactically, wherever these can be used. So Dr. Rubeena, coming to you, what do you think are the advantages of using nebulized antibiotics in today's day and era when we actually have such a wide array of antibiotics available? So do you think there is any advantage of using nebulized antibiotics?
Definitely, there are a lot of advantages of using this nebulized antibiotic. Like in today's scenario, everybody is using antibiotics everywhere, even the quacks and the grassroots level, everybody is using the antibiotics, and the cases of multi-drug resistance are coming up. So in these patients, giving a nebulized antibiotics is a very good choice, and moreover, the advantages lies behind it. There is a direct hit on the areas infected, like that.
Dr. Rubeena, we've lost your voice.
Now is it audible?
Yes, yes.
Then high dose deposition, limited systemic absorptions, and limited side effects. All these add on to gives an edge over to the systemic antibiotics. So definitely inhaled antibiotics are more helpful.
So like Dr. Rubeena says that, of course, it reduces the systemic toxicity of antibiotics. So that's why nebulized antibiotics certainly have a way forward. Dr. Joydeep, while we're talking about indications, what do you think? I mean, we've discussed about prophylaxis, therapeutic and chronic in acute cases. So do you think, does it also have a role in sinus infections, which we see very commonly even in our OPD practice?
Okay, well, Shivani, the problem is that with CRS or chronic rhinosinusitis is whenever we try to give nebulized antibiotic, we need to have a culture positive report. Such as cystic fibrosis, we have pseudomonas positive infection, so we give specific antibiotic. But the problem with this chronic rhinosinusitis is it's actually polymicrobial disease. If you see there is both gram positive and gram negative bacteria are present, especially we have the streptococcus pneumoniae, we have Moraxella catarrhalis, we have Haemophilus influenzae, also we have some aerobes and anaerobes also there. So being polymicrobial, there is no such effective part when we can give a combination of antibiotic and give them as an evaluation form. If you see the evidences, if we say normally what happens in chronic rhinosinusitis, we first give them some oral antibiotics, then we give them inhalational intranasal steroids, and we have also give them nasal irrigation. And lastly, if the symptom are refractory, we give them functional endoscopic sinus surgery. But the problem is that after even FACE or functional endoscopic surgery, 15 to 27% can occur with a recurrent symptom. So in that kind of patient, we can use this kind of nebulized antibiotic. The problem is that two things. First, we have to get a proper culture report of the nasal flora, especially the sinus irrigation. After sinus irrigation, so the culture report is very much important. And if it is mixed flora, we can't give them single antibiotic because our choices antibiotic is very low. We have only this polystyrene sodium and this anti-pseudomonal. We have this tobramycin. But if there is a gram-positive bacterial infection, I don't know how we can give it. And also another thing is the deposition of aerosols, such as in the lungs, during our mouth, it is very great. But in the nasal sinuses, the obstructions, because there is always a nasal congestion, especially in the acute exacerbation, there is also mucosal hyperplasia, there is nasal congestion and mucosal overdrive is there. So the penetration is also questionable. So if we see the evidences, there are 4 trials in a meta-analysis, and they all conclude that these are okay, but we need more randomized control trial with a higher sample size, because they are small trial taking 40 to 20 number of patients, and they all conclude one thing, that it is only at a last resort, not at a final resort, whenever the patient is refractory to all the other therapies, and only if there is a positive culture report is there that is pointing to a specific resistance to specific antibiotics. But otherwise, it is not in the guidelines. Both we have seen the many guidelines about the CRS treatment, but nobody is specifically mentioned this kind of aerosolized antibiotics in case of chronic rhinosinusitis treatment.
Right. So Dr. Joydeep says that, of course, very correctly, that unless we have a positive culture in patients who are refractory or have recurrent problems, it is not as advisable to give inhaled aerosolized antibiotics. Also, because there are a lot of challenges about penetration and drug bioavailability at the site. So, Dr. Richa, you were talking about prophylactic antibiotic therapy, especially in the aerosolized form. Of course, you talked about Niscarina, which was a very valid point. So, can you please highlight for us that, for patients who are actually taking antibiotic in aerosolized form at home, what are the preparation that they basically need?
So the first dose is always given in the hospital. It's basically the test dose and the tolerance test that is done in front of the physician. If you have a spirometry, that's good. If you don't have, then you watch out for the symptoms. And you give the first dose, and after 15 minutes of that, if you have a spirometry and the patient has a drop in FEV1 of more than 15% or maybe more than 200 ml, then you will basically give the bronchodilator and then give a second trial of that nebulized antibiotic. And if you don't have a spirometry, then you will watch out for the symptoms such as cough, wheezing, or bronchospasm and dyspnea. And if the patient gets these symptoms, then again, you will give the bronchodilator, then again try for the nebulized antibiotic. And you will watch out the symptoms for at least 30 minutes. If there is no reaction to that, then you can safely give it at home. Now, once you have given it at home, the patient as basically depends on drug to drug and what kind of nebulizer that we are choosing. As you said, that it depends. In the jet, there is less aerosol deposition. If we are giving portable mesh nebulizer, which are now easily available, so it will depend on that and basically what drug we are giving. And it's usually reconstituted with sterile water, especially colistin, which is reconstituted with sterile water to get less bronchospasm. And then best to give is in bronchitis patients at least, or CF patients at least, that you first give the bronchodilator therapy, then you do the postural drainage, and then the last thing that you give is the inhaled antibiotics. So basically you're clearing the airways and then you are going for the inhaled antibiotics. And once you have given that, you should always tell your patient about the warning symptoms of cough, chest tightness, wheezing, breathlessness. The one thing also that you should teach the patient and the relatives is that whoever is in the room, it should be a well-ventilated room, because there is a major concern with this inhaled antibiotics is the environmental deposition. And there are cases, although they are rare, but there are cases where the relatives or the bystanders who actually gets bronchospasm with these inhaled antibiotics. So we need to take care of that. And once they are done with the therapy, if it's 10 to 15 minutes of therapy, they need to clean the nebulizer after each use and let it air dry and then use it next.
Right. So Dr. Richa very correctly told us that, of course, that we have to obviously always give the first dose in the hospital and sometimes the second dose as well, which is preceded by a bronchodilator in an inhaled form. And tell the patients symptoms to watch out for, take it in a well-ventilated room, and they should know basically when to report to you, even in cases. And certainly she's talked about telling the patient about, cleaning the device even after use, which has to be done after each use. So excellent. So while we're talking about nebulizers, Dr. Rubeena, what do you think, which one of the three nebulizers that we've used, which is the jet, the ultrasonic and the mesh, which one do you think, supersedes the other, and in what way?
We have already talked, like you have already discussed in the slides also, the three of the nebulizers, the jet, ultrasonic and the mesh. And jet is one, we all know that it is low cost and it is easily available and everybody is using it. But the major disadvantage with this, the chamber. The chamber, in that the residual volume that is left behind, it is much, and the drug that is delivered to the patient is less. So that becomes one of the major disadvantage of using a jet nebulizer. Above all, the noise is loud and it needs a compressed gas to generate the fumes. With ultrasonic nebulizer, there is heat. The heat that is produced that causes the drugs to get degenerated, and thus it causes less drugs is delivered to the patient. So hence the vibrating mesh nebulizer becomes an edge over, because that is small in size, easily portable, silent, and the drug delivered is the maximum. Small residual volume is left in that. But the only disadvantage with the mesh nebulizer is that the high cost. The cost of the mesh nebulizer is really high that everybody cannot afford in the country like ours.
Absolutely. Very, very correctly said. And like Dr. Rathi has explained, that when we are using the ultrasonic, the potency of the drug can actually be affected to a very, very high level. Also, I would like to add, when we are using the mesh nebulizers here in India, so like colistin, most of the people, like Dr. Joydeep has already said that, we reconstitute the injectable powder basically that is available for IV use, and we reconstitute that and use it as a liquid form to, aerosolize or nebulize the patient with that. So when we're using the mesh nebulizer, a lot of the mesh can actually get clogged with that solution. It's not meant for nebulization with a mesh nebulizer, which can be a problem until you are sure that the mesh nebulizer that you're using can actually forego that problem. So I think, so Dr. Richa, coming back to you, we were talking about nebulizer at home. So in your hospital practice, which are these patients where you use aerosolized antibiotics?
So in hospital practice, one is ventilator-associated pneumonia or any nosocomial pneumonia for that matter. If the patient has MDR pathogen and with IV antibiotics, usually the adjunctive therapy is inhaled antibiotic that we use, and nebulized colistin is the most frequently used antibiotic. And we are looking at MDR pathogen that could be Klebsiella, Pseudomonas, or Acinetobacter, which all three of them are targeted by colistin, and more so in Acinetobacter. And even again, coming to the point that even if your patient doesn't have an MDR pathogen on the sensitivity report, but your patient is not responding just to IV antibiotics, a trial of inhaled antibiotics should be considered in such patients. So ventilator-associated pneumonia is one where the acute condition, and then definitely post-lung transplant patients. So if your hospital has the lung transplant patients, then post that as a prophylaxis that we talked about, liposomal amphotericin B, which is used especially in high-risk patients such as cystic fibrosis, or maybe elderly patients or patients who have complicated post-operative period. There we use liposomal amphotericin B, and it is used basically for 3 months. And also, again, inhaled pentamidine can be used in such patients. And again, nebulized colistin can be used to treat pneumonia in these patients. And also in these patients, targeted therapy can be used for patients who have airway colonization, although they might not have a disease per se, but the airway colonization by Aspergillus or any MDR pathogen, but they don't have signs and symptoms of the disease. Because these are immunosuppressed patients, we do give inhaled antibiotics in these patients for longer duration, so as to basically we are targeting eradication and to prevent and decrease the morbidity and prolonging the survival in these patients.
Right. So while you're talking about using Ampho B as a aerosolized form, one question actually crops up in my mind, since we've all been through a bad COVID phase, and I think after the second wave, a lot of us actually came across patients with mucor and sometimes even aspergillus for that matter. So do you think there's any role of inhaled Ampho B in these patients?
Sorry, I didn't get you.
Patients who were actually suffering from lung or sinus or mycosis or aspergillus infection, do you think there's any role of inhaled amphotericin B in these patients?
So this is not well documented. Maybe we don't have substantial evidence for it, but then certainly the patients who are not responding in the trial can still be considered.
Yeah, I think it will be worth to try, because that's been very notorious infections that we've all come across in the recent days. So I think maybe when we next get a patient, we should all together maybe try that, and maybe we can print a paper when we get to that. So I think that's about that. So Dr. Rathi, coming back to you, while we are talking about hospitalized patients, I'm sure a lot of these patients are actually on ventilators, like Dr. Richa has already stated that, patients with VAP. So what do you think about using it in patients who are on mechanical ventilator for whatever reason?
Actually, once the patient is on mechanical ventilator, there are a lot of IV antibiotics we have already tried, and the patient is moreover exposed to get multi-drug resistant pneumonias, VAP, ventilator-associated pneumonias, or ventilator-associated tracheobronchitis. So in these patients, definitely nebulized antibiotic is edge over. And as you have already discussed, that in ventilated patients, we use certain parameters are there to use these nebulized antibiotics. Like we have to put the nebulizer position, the position of the nebulizer chamber is very important. Like it has to be placed in the inspiratory arm 15 to 20 centimeters away from the Y piece to have the maximum availability, and the settings of the ventilator and settings of the ventilator are also changed to have the maximum availability. Particle size is also changed, and the drug concentration. That all these factors with humidifier in the circuit and the heat circuit has to be stopped. The dry circuit has to be used to have the maximum availability of the inhaled antibiotic to the patient on ventilator. So these factors has to be kept in mind, because if the chamber that is being used at the beyond the Y piece, in between the ET tube and the Y piece, then there are chances of loss of the inhaled antibiotic in the expiratory limb. Then there could be like the antibiotic can be moving into the both the limbs. So it is not available 100% available for the patient, because although the limb is long and there is some loss of antibiotic in the circuit also. So we have to take care of the chamber, plus the ventilator settings are very important in all these situations.
Absolutely, absolutely, can't agree more. And while we are actually talking about use of, inhaled antibiotics in the ICU, there was a survey published not very, many years back. It was, I think, in 2019, where in the US, they actually did a survey in at least 192 ICUs about the use of inhaled antibiotics. And you'll be surprised to know that at least 43.7% were not using inhaled antibiotics because they did not know how to use it. So I think that's a very interesting figure. I think while I'm talking to you all, I realize that, we know so much more. So I think there we are literally a little ahead of those.
Actually, that becomes really important in today's scenario, that maximum, what I feel in India also, maximum of the people are not using the inhaled antibiotics. In my city also, maximum of the consultants and the intensivists, they are not using inhaled antibiotics, because the staff is not trained. They don't know how to use it and how to put it. So that becomes really important. The training part should always be there for the staff, and the ICU training should always be given in this area.
Absolutely, absolutely. I think that's a very valid point. And I think CCI has hence chosen a very, very important topic for today's webinar. So with that, going to Dr. Joydeep, while we're talking about, preparation of antibiotics and training with the staff. So what do you think is better in terms of, delivering as aerosolized therapy, the dry powders or the solutions that are available? Of course, we have very limited choices when we are talking about inhaled antibiotics here in India. But what are your thoughts?
Yes, definitely, Shivani. So we all pulmonologists know that the difference between the DPI, the PMDI, and the nebulized is always depends on the patient's perfection and patient's condition, and also patient preference. So regarding, if we see the availability internationally, only 3 antibiotics are available as a dry powder form. If we see, the first is the TIP or tobramycin inhalation powder. The second one is the colistin dry powder device. Another is a ciprofloxacin dry powder. Only of this, there is some studies was going. So one study by Constant, he compared with the TSI, that is the tobramycin solution for inhalation, and tobramycin inhalation powder, and they found that it is non-inferior to inhalation. So the TIP or the dry powder is actually non-inferior to this in the nebulized solution in respect to clearing of the pseudomonas colony and also lung function and other parameters. But the advantages of DIP, it is easy to administer, faster acting, and also potent. So wherever we are using 300 milligram of nebulization solution in case of tobramycin, we have to use only 2 milligram of tobramycin in case of dry powder inhalation. So there is a less amount of drug is going, so there is a less side effects also. But the problem is that with dry powder inhalation, that it has got some serious local effects, like the patient have complained that there is a more cough, there is a more bronchospasm, and also more irritability in the respiratory tract. And there is other study also which compared colistin dry powder inhaler with TSI or tobramycin nebulized. It is also shown that it is also non-inferior, but again the local symptoms are much more, and again the ciprofloxacin also same. So I think it is not available still in India, but it also depends on the patient preference, also doctor preference, because most of the patient we see in the ICU and the cystic fibrosis and non-cystic fibrosis chronic bronchitis patients are admitted in hospital. In that cases, their respiratory flow is much less. So in that case, depending on the patient choice and patient preference, also patient eligibility, we must choose what kind of delivery device we want to give them. So in that case, I think most of the ICU and in-house patient should be on nebulized antibiotic. And if any patient have appropriate inspiratory flow and is the availability is important also in India, then we can use that, because it is easy to administer and easy to follow.
Sure. So since you were talking about, patients developing cough and everything, and since Dr. Richa also was mentioning about, bronchospasm, especially when, give a supervised first dose. So Dr. Richa, would you want to tell us if there are any other adverse effect or disadvantages when we talk in terms of aerosolized antibiotics?
Yeah, so one is definitely local side effects that we are talking about. Bronchospasm is the major concern. The patient can have sudden wheezing, cough, chest tightness, or dyspnea, and maybe hemoptysis also rarely. Then there are certain reports that we've used inhaled tobramycin very commonly in bronchiectasis patient, and there are certain reports of voice alteration and tinnitus also with inhaled tobramycin. But all this is basically transient, and it's more mild to moderate degree. And when we give that on-off cycles of 4 weeks and then off cycle, it usually reverts back. So that is what the side effects are there. They are rare, first of all, and then they're transient, reversible in most of the cases. There is slight concern of systemic side effects, which are reported in very, very few cases, but then there is a concern about that, and specifically when we are giving inhaled aminoglycosides of nephrotoxicity and ototoxicity, but then they're very rare, uncommon. Then there is a theoretical risk that maybe when we are using inhaled antibiotics, we are actually favoring, and maybe we are more favoring growth of resistant organism. But that's not the case, because cystic fibrosis patients have long been studied. They have been given inhaled antibiotics for long, even 12 to 18 months. And there are numerous reports, numerous trials which have shown that resistant organism is more of a theoretical concern. It's not really seen. It doesn't really increase with inhaled antibiotics. So there's a concept of a mutant protective concentration, that if the drug level is above that mutant protective concentration, that you won't give rise to resistant organism. That is and that is what is seen with inhaled antibiotics, because the drug dose is exponential to that of the systemic dose. That's why you don't give rise to resistant organism. It's actually more of a protective thing. So that's a theoretical risk, but that's not seen. And that when we give inhaled antibiotics, we are not giving rise to resistant organism. Then there's another issue. Compliance is the major issue, because some of the drugs are more in the BD dosing or maybe TDS dosing. And then you have to use a nebulizer, cleaning the nebulizer, then infections, that is the cause because of the use of the delivery device. So that is one of the concern. Cost is another concern. And then also that the point that I talked about earlier, also environmental handling, that the bystanders and the relatives, they are exposed to these drugs, because whenever we are using nebulizers, specifically jet nebulizers, so a lot of drug goes to the environment also, and the patient and the people who are there in the room, they are also at risk of bronchospasm. So we need to be careful. We need to teach the patients to be in a well-ventilated room. So these are certain concerns, and cost and definitely compliance are also other concerns for these inhaled antibiotics.
Right. Thank you. So while Dr. Richa was talking about, patient factors, a lot of patient factors, Dr. Rubeena, what do you think are actually the patient factors, which affect the drug delivery when we are using the aerosolized form?
Actually, there are basically 4 factors that affect the drug delivery. First is the size of the diameter of the airway, the large airway. In the normal lung, in normal adult, up to like 5 microgram particle can also, when the patient inhales it, it reaches the central airway. In children, the airway is narrow. So, but the force of turbulence, the inflow inspiratory airflow is high, so that the drug can deposit in the central airway. The second factor is the inhalation maneuver, how the patient is inhaling the drug. That becomes one of the important factors. It depends on the age, the physical capability, the diseased lung, and the cognitive ability of the patient to perform specific inhalation. Even if the patient is like very well versed with the maneuver, then also they tend to have a little bit airway. They are not able to do it properly. So third factor that comes is the structural abnormality of the lung and the mucus impaction in between the airway. Like if the mucus is impacted, then there is distortion of the airways and the drug is not able to reach to the alveoli, the end on disease. The fourth factor, that is the ability of the lung to expand. Like we say in COPD patients or in cystic fibrosis patients, there is change in the structure of the lung, so the drug is not able to reach to the end on point. So these are basically the four factors that affect the delivery of the lung as per the patient.
Right. So the diameter of the airway, the inhalational technique, and the capacity of the patient. Other than that, of course, structural abnormalities or mucus impaction and lung expansion. These are the major factors. So, Dr. Ganguly, can you think of any other factors apart from the, the patient-associated factors that, Dr. Rathi has very beautifully explained?
Yes. So we have seen the patient factors. Now the other factors are different. So we have these, actually it is already been beautifully demonstrated by your presentation. So we have this drug formulation. It depends on the particle size. Also that depends on the delivery system, which delivery system are we using. Also selection of the inhalation device and inhalation technique. So if we see the particle size, it is actually between 0.5 to 10 micron. So there is three, I've already told that impaction, sedimentation and diffusion in these three process, this DPI and these aerosolized particles actually get deposited in the lungs. So if you see in the nose and mouth, they actually cover the more than 10 and more than 15 micron of particle. And then in the first 1 to 6 generation, about 5 to 1 micron particles are sedimented, and then in 5th to 6th generation, 1 to 5 micron particles are deposited. So it always depends on the how much size the particles are we using. Then again, regarding the device we are using, so we can use jet nebulizers or we can use ultrasonic nebulizer. We have already seen from your presentation that jet nebulizer wastes a lot of aerosolized particle. Is actually 95% of particles are lost, and only 1/3 is actually going into the patient's respiratory tract. Also, they are depending on the mass median, aerodynamic diameter, also the fraction particle factor, the age of the patient, whether we are using any face mask or mouthpiece, the treatment time, the drug, the inhalation device can use all the drugs, or it is a customized for a specific drug. Also the assembly, portability and usability. These are all important in defining whether it is usable or not. Regarding the DPI devices, we have these three types of devices. It may be of low resistance, it may be of medium resistance, or it may be of high resistance. So depending on the patient's inspiratory flow, we can choose the typical DPI device, and also the storage, whether it is in a airtight container, in a blister pack, whether it is in a properly packed manner. Also dose counter is present on, because dose counter, I think from my personal experience, dose counter is very much important, because patient may not notice there is a empty doses and he's taking the empty container just in PMDI. So these are the most important factor, I think.
Dr. Rathi, any other inhalational method that you can think of delivering the these medicines that we're talking about?
Yeah, you have already discussed in the slides that meter dosed inhalers are one of the techniques that is being used because these are easily available also. But unfortunately, in meter dose inhaler, what we do is that the antibiotics are not available in India. So that becomes a constraint for us of using that meter dose inhaler in the patients. But basically, we use that with a spacer, and it is same, the position of the inhaler, the MDI and the spacer is the same as we place it for the other nebulizer chamber. For the jet nebulizer, like we place it in the inspiratory lane 15 to 20 centimeters apart. The canister is used, but the canister that is used, they say few of the studies have been done which says that the same canister can be used, and it becomes cheap for the patient and everything. But at times we need to change it because there is a effect of like cross contamination and ventilatory associated pneumonias. But with the mesh nebulizers coming up, few studies say that there is hardly any difference of using MDIs and mesh nebulizers, because both of them are equally effective and equally effective for VAP and VAT.
Correct, absolutely brilliant. So, Dr. Richa, coming to you, so do you think there is any effect of heat or humidity that we've discussed, when we're delivering these medicines in an aerosolized way, especially, in the mechanically ventilated patients, because, pulmonologists are obsessed with the heated humidifiers.
Yeah, so you mentioned in your presentation also that heat and humidification, basically what they do is they decrease the aerosol deposition because the particle size increases, and we are aiming at a particular particle size, that range, that is we are looking at 1 to 5 micrometer. And when this happens, the size increases because of the humidification and the heat, and the drug delivery will be less, definitely. And we usually use either of the two. So it's like the active humidifier, or we use HME with or without filters. Now, when we use active humidifiers, then the drug delivery is decreased by almost 40 to 50%. So it's best to stop the active humidifier at that time when you're delivering the drug. There are recent studies which are showing that even when with the humidifier on, the drug delivery doesn't really change and the clinical outcomes are same, but we don't have enough evidence for that still. So although the data is coming up, but till then we can maybe preferably use dry circuits or maybe switch off the heated humidifiers. And when we are using HME, then best is to use the aerosol delivery device between the HME and your artificial airway, the ETT, or best to use without filter, because when you are using with the filter, that the drug deposition reduces to almost 3 to 5%. That is it. And when you are using without filter also, if you're using HME, then also the drug delivery decreases by around 50 to 60%. So whenever you are using HME, or you are using active humidifier, the drug delivery, the dose will be reduced. So when you're using active, you can switch off them. And if you're using HME, either you can just take out the HME or use it without the filter. Or if at all you are using, then replace your aerosol device between the HME and your artificial airway.
Right. So I think we've really discussed at length about, patients generally at home, or patients in the hospital, or patients especially on mechanical ventilator in one way or the another, either through tracheostomy or through a ET tube. But one thing which was very, very common, one medium, which was actually like a bridge between, patient on oxygen and a patient on ventilator, especially during the COVID times, and something which has become extremely popular is HFNC. And I think now pulmonologists are extensively using HFNC today. So, Dr. Ganguly, can you actually tell us if there is any way we can use aerosolized antibiotics while we are using, while the patient is on HFNC?
Definitely. Because, Shivani, we know that for the past 3 years, we are increasingly, especially in the COVID pandemic, we increasingly are using this HFNC, mostly in case of acute respiratory hypoxemic respiratory failure. Now, as these patients are mostly depending on the high flow oxygen, we need to have a strategical point in case of giving aerosolized antibiotic, because we know that already we are in a high pressure system when we are giving a high flow oxygen and concentrated oxygen. So whenever we putting another aerosolized device, what happens? The flow may get disrupted, and also there may be loss of aerosolized particles, and also there will be denaturation also. So there are some things we need to be taken care of. So the first is the nebulization selection. We definitely prefer mesh nebulizers over jet nebulizers due to their greater efficiency during HFNC therapy, and we should use an aseptic technique to prevent the contamination of the nebulizer during the device preparation. Secondly, the nebulizer placement, that is very important. So we should always place the nebulizer in the dry side of the humidifier, that is the inlet of the humidifier, to improve the aerosol delivery through the HFNC. And we should definitely close the reservoir cap after use. Now, if we see the HFNC cannula prongs, we should use larger HFNC cannulas, but we do not need to block more than 50% of the cross-sectional area of the each nostril. And also, we need to see whether there is air leakage or not. Also, regarding gas flow, because we are giving it a higher flow rate, we definitely need to decrease flow during aerosol therapy, because the flow and the aerosol deposition is an inverse relationship. So if it is tolerated by the patient, we definitely have reduced the flow rates so that the aerosol got deposited more. Also, the delivery technique is very important. So between the intermittent and continuous therapy, we should definitely prefer intermittent therapy. And also the HFNC should not be discontinued. It should be continuously given with this aerosolized solution. And also regarding those points, so the important thing is we have to set a system where this HFNC and nebulizer can coexist in a specifically manner. So we can see if we reduce the flow rate, there is actually 3 to 12-fold increase in the aerosol drug delivery, and the inhaler dose is higher when the HFNC flow rate was set below the patient's inspiratory flow. Is very important. And also they should always monitor the patients closely during aerosol therapy, because we are reducing the flow, so there may be loss of desaturation is there. So we may have to look after the FiO2 also. And also mesh nebulizers, if you've seen that, it actually offers 2 to 3 times higher inhaled dose than jet nebulizers. So because it has got low residual volume of drug remaining in the nebulizer cup after therapy. So these are the important point, I think.
Correct. So we can also use it with HFNC. So isn't that wonderful?
Definitely.
I think we need to reduce the flow less than to the patient's actual flow, like Dr. Ganguly has said. And I think with this, we practically sum up the major uses and the major antibiotics that we've used. I think we'll move on to taking questions from the audience now. So the first question is actually, what is the dosing of aerosolized colistin that is preferred? Dr. Richa, would you want to answer this, please?
Yeah, so if we go by the reports and the studies, colistin dose has been between 1 million unit BD to even 2 million units BD. But usually for patients of BAP or HAP, we use 1 million unit TDS and or BD dosing. And for bronchiectasis patient where we are aiming at long-term administration for at least 3 to 6 months, we use 1 million unit BD dosing. So, yeah.
Right. I think a lot of these questions will be a repetition to what we've practically discussed, but if people still want it to be re-answered, can you please type them again? So the next question is actually from Hyderabad, which are the antibiotics that can be given in nebulization and what dosages? I think we've discussed this. Next is from Delhi by Dr. Arora. He says, please name the common antibiotics used for nebulization. I think we've done that as well. The next question is from Mulana Ambala. I think the hosts for the prestigious NAPCON. Many physicians are tempted to use commercially available forms of antibiotics for parenteral use as nebulized medicine. What are the pros and cons of this type of practice? What is the difference between the nebulized medicines? So I think we have actually discussed it. But Dr. Rathi, would you like to sum it up for Dr. From Mulana, please?
Can you please repeat the question, ma'am?
G. So Dr. Jay Kishan, I think it is, who is asking that many physicians are tempted to use commercially available forms of antibiotics for parenteral use as nebulized medicine. What are the pros and the cons of this type of practice wherein we use the, the parentally available forms in nebulized form? So he wants to basically know the pros and cons of this practice.
Actually, whatever the commercial antibiotics are available, basically the problem is the particle size. The size of the particle is bigger, so that becomes the bioavailability for the airway availability decreases for the antibiotics. So that becomes one of the major issues. And there are no such studies that say that the parenteral antibiotics, the injections can be used in nebulized form. This is what I get.
Yeah. Absolutely. I would also like to add that the major cause of concern with using IV antibiotics as aerosolized will be actually toxicity of the, the additives, the preservatives of the IV formulation, which can lead to bronchospasm like we have discussed. And also, I think the osmolality and the pH of that formulation may not really be optimal for use as a aerosolized form. So I hope that answers your question, sir. And next is an excellent question from a very respectable senior colleague of ours, Dr. Jayaraman. I think everybody knows him. Hi, Dr. Jayaraman. It's nice that very sweet of you to be attending this session. So sir wants to know if there is any nebulized ATT. Dr. Richa, would you want to answer this, please?
So aminoglycosides are something that we use, we've been using in NTM. And also, I think there are reports of nebulized isoniazid or rifampicin also. That's what I recollect, that although not, there's no recommendation, there are no guidelines for that, but there are certain reports of that. Aminoglycosides, yes, for sure, can be used in a nebulized form. Amikacin has been used. And I think there are no other ETT that I can think of. Fluoroquinolones are one that, like levofloxacin, has been used. Nothing else that.
Correctly. So I think fluoroquinolones, whether it is levofloxacin and sometimes even moxifloxacin, ciprofloxacin, has been used. So maybe moxifloxacin and levofloxacin. Also, like you were saying, that aminoglycosides and sometimes maybe ionogen rifampicin. So I think very many years ago, maybe decades back, there used to be this combination available of streptomycin and isoniazid in an injectable form. I think maybe that could have been used as an aerosolized form if it was available. I don't think it's available anymore, but I think many, many decades ago that I've only heard of it. I have never seen it myself. So there is this another question from Kerala, that how long is colistin preferred when given in aerosolized form? And how long is the duration of the course that you would want to give it? Dr. Joydeep, would you want to talk about that, please?
There is an actually clear practice guideline for that. So in case of cystic fibrosis specifically, we can have two things. We can give it continuously for like 3 months, or we can release 28 days off and on therapy. So we can cycle it. And whenever we given it in VAP or like ventilated pneumonia or hospital-acquired pneumonia, where there is an acute problem with the MDR pathogen, we can give it for a few days. So it's also depending on the individual patients and what indication we are using it.
Right. So I think we have exhausted most of the questions. There's one last question. In the meantime, I would request the audience, if there are any more questions, anything, any doubts, you can please type it again. We are happy to answer those. In the meantime, Dr. Rathi, I'll come to you with the last question so far. Is there any indication, Dr. Jayakishan again wants to ask whether there is any indication and advantages of using DNase or N-acetylcysteine along with these nebulized antibiotics.
Practically, I have not used it along with the antibiotics. Individually, we have used it, but not along with the antibiotics. So sorry to say, I don't have any experience in this area.
Right. So I think like Dr. Richa was saying that while, for patients of bronchiectasis or cystic fibrosis, when you want to first clear their airway before, maybe instilling these aerosolized antibiotics, I think that's one place where we could be using N-acetylcysteine even in a nebulized form prior to, initiating the use of the inhaled antibiotics. So I think that's the questions that we have so far. And if we don't get any further questions, I would just request each of you to individually, talk in detail about your own experiences and your own setups, in terms of using aerosolized antibiotics. So Dr. Rathi, since we are...
Actually, in my city, what I have come across few of the patients, and in that we have used the inhalation antibiotics, and basically what I have used is tobramycin inhalation therapy, and it was like 15 days on and off thing that we have used, and that becomes quite easy for the patient to go home on those. Once they are there in the hospital, they are being trained how to use it and how to handle that. But unfortunately, we don't have used it with the mesh nebulizers, because that becomes one of the constraints is the cost, and their cleaning, their training, that becomes difficult for them. So we have used it with jet nebulizers only. So I have used Tobamist as one of the things. And in ventilated patients, we have definitely used colistin in 1 million international unit in few of the patients unresolving pneumonias. So that, and definitely the patients have responded very well to the inhaled antibiotics. But not only what we have used is like during the stay in the hospital, the patients are on the inhaled antibiotic as well as on the IV antibiotic. So that becomes a dual effect with a quick check on the parameters, the patient parameters, how the patient is going, how the output, and all the other parameters related to the patient that we have come.
Correct. Dr. Richa.
So yeah, same here that in ventilator-associated pneumonia, very commonly used that I have used and I have seen that nebulized colistin, especially for MDR organisms and along with IV antibiotics. Even in bronchiectasis patient, the patient is having frequent exacerbation, or even if not frequent exacerbation, there is that he's coming back and there is increased morbidity, decreased quality of life, and there is chronic colonization of Pseudomonas or any other organism. Then also inhaled antibiotics I've used even at home, inhaled tobramycin for that matter, and commonly used 300 milligram BD dosing. Another that I've seen in last 1 year in lung transplant patient, that prophylactically also nebulization with colistin, specifically if there is a bronchiectasis patient or COPD patient with a documented colonization of Pseudomonas, there also the transplant team has used prophylactic nebulization colistin, and that just continued after in the post-operative period also. So there are these three conditions where we've commonly used basically nosocomial pneumonia, bronchiectasis patient with chronic colonization, and then transplant patients.
Correct. Right. Dr. Ganguly, I would like you to conclude, please.
Yes, Shivani, I have also the same experience. So apart from VAP infection, we can use this nebulized colistin. But I would say a specific segment of patients, especially those who have bronchiectasis patient with recurrent exacerbation, we have a cost cutting because we can give them a home nebulization with the tobramycin, and after 10 to 15 days of therapy, what happens is actually it reduces their hospitalization, it reduces their overall expenses, and also improve the quality of life. So also have this pre and post nebulization culture also we have done, and it got a good result. So we can definitely say, so if we do this patient home nebulization, not all the patient, but a particular set of patient when there is a culture positive, sensitive to tobramycin, we can give them a home nebulization therapy off and on, and it can definitely reduces their exacerbation, also improve the quality of life, and also reduces the recurrent infections.
Right. So I don't think we've gotten any more questions, although Dr. Jayaraman says I'd like to compliment all of you and pass his greetings that it was an excellent discussion on nebulized antibiotics. He thanks CCI and he also thanks all of you for the wonderful discussion. So I think it has practically been much appreciated. Thanks to you all. I would like to just give a concluding remarks after which we can end. So I think the basic things that we have when talked about, of course, the various nebulizers that are available, the superiority of the mesh nebulizers, of course, cost being a major concern for most of us practicing in tier B or tier C cities. I think that's going to be always there when it comes to Indian circumstances. We've discussed the various mechanical ventilator, the various factors that basically affect the drug deposition, which includes the patient factors, the equipment factors, and also the if the patient is on mechanical ventilator or HFNC. So I think we've covered majorly all aspects of this. A few things that I would like to highlight towards the end for the convenience of our audience. So the most important antibiotic features that are essential when we are talking about aerosolized antibiotics. It should be soluble in solution form and hence should be deliverable as as an aerosol. It should kill bacteria in a concentration dependent fashion. It should be active in the lung and should not be degraded in the process of delivery. It can penetrate sputum or lung secretions. It should have minimal systemic absorption, and it should not be injurious to the airway surface. I think this is what together all of us have concluded. Also, it should be preservative free. The pH range of the solution should be between 4 to 8, which is a very wide range. The tonicity and osmolality should be practically compatible with our body, and the particle size, like Dr. Joydeep had said, that should be between 3 to 5 microns. So I think we would all agree to this. And with that, I would like to thank all the panelists. You've added on to my knowledge immensely today. And I think we all conclude with the thought that when we're talking about aerosolized antibiotics, they certainly assist in eradication of MDR pathogens, and we can be used as salvage therapy for patients failing systemic therapy. Of course, it can also be used as prophylactic in the various conditions that Dr. Richa had highlighted. And it certainly can be used for a long-term therapy when even in colonization in patients of bronchiectasis or cystic fibrosis. And when we talk about guidelines, although there are no clear-cut guidelines, the last IDSA and ATS joint guidelines actually stated that there was very weak recommendation and low quality of evidence for using aerosolized antibiotics, but we have all tried to make the subject clear to you. Of course, you're free to take your call. We have tried to be unbiased. We have shared our own experiences with you. And with this, I would really like all of you to be so patient to be here. And thank you, everybody. And special and warm thanks to all the panelists. I think we've had a great discussion and we've covered practically everything. And it could not have been possible without you all. And also in the end, I would like CCI to give us this opportunity to be here. So thank you, everybody.
Thank you from my side to everyone, and especially Krishna sir, Shivani ma'am, Richa ma'am, and Joy sir, everybody. Initially, I was like very out of mind, how am I going to do it? But it was all because of you people that I was able to do it. Thank you so much.
No, Dr. Rubeena, you've done an excellent job. You've added to our knowledge immensely. And I think we've had a very fruitful discussion. And there is another compliment that has come from Dr. Jaikishan. He says that congratulations to the moderators and panelists for elaborating excellently the topic of nebulized antibiotics, which have several advantages. So I think you've done an excellent job.
Thank you.
Thank you. Thank you.
Thank you, everybody. Good night with that.
Good night.